oral food intake. The elevation in GIP and GLP levels is known as the incretin effect. In addition to increasing insulin secretion from beta cells, these hormones reduce glucagon secretion from pancreatic alpha cells and delay gastric emptying, which promotes satiety. Once released, circulating GIP and GLP are degraded in the circulation by a class of enzymes known as dipeptidyl peptidases DPPS, especially DPP. The incretin effect is significantly blunted in patients with TD, and efforts to restore incretin function can improve glycemic control and promote weight loss through restoration of satiety. These insights have led to the recent development of two classes of drugs for treating T2D GLP-1 receptor agonists, which are synthetic GLP-1 mimetics that bind to and activate the GLP-1 receptor on islet and extrapancreatic cells, and DPP-4 inhibitors, which enhance levels of endogenous incretins by delaying their degradation. GLP-1 also increases energy expenditure, so the weight loss-inducing effects are likely multifactorial. Indeed, GLP-1 receptor agonists are also now approved for treatment of obesity. Insulin action and insulin signaling pathways. Insulin is the most potent anabolic hormone known, with multiple synthetic and growth-promoting effects, FIG. The principal metabolic function of insulin is to increase the rate of glucose transport into certain cells in the body, thus providing a major source of energy and metabolic intermediates derived from glucose that are used in the biosynthesis of cellular building blocks such as lipids, nucleotides, and amino acids. The most important targets of insulin action are striated muscle cells, including cardiomyocytes, and to a lesser extent, adipocytes, which together normally represent about 2/3 of the body's weight. The type of adipose tissue that utilizes the most glucose is, figure, metabolic actions of insulin in striated muscle, adipose tissue, and liver. Beige adipose tissue, which develops with exercise, and not the white adipose tissue that accumulates in obese individuals. This is one reason why exercise is beneficial and obesity detrimental to glucose control. In muscle cells, glucose is either stored as glycogen or oxidized to generate ATP. In adipose tissue, glucose is primarily used as a substrate for synthesis of lipids, which are stored as triglycerides. Besides promoting lipid synthesis, insulin also inhibits triglyceride hydrolysis and lipid release by adipocytes. Similarly, insulin promotes amino acid uptake and protein synthesis, while inhibiting protein degradation. Thus, the anabolic effects of insulin are attributable to increased synthesis and reduced degradation of glycogen, lipids, and proteins. In addition, insulin has several mitogenic activities, including initiation of DNA synthesis in certain cells and stimulation of their growth and differentiation. The metabolic effects of insulin are exerted through its binding to the insulin receptor, which, in turn, sets into motion a series of signaling events through an array of mediators, the more pertinent of which are summarized in Fig. 24.30. The insulin receptor is a tetrameric protein composed of 2 alpha subunits and 2 beta subunits. The beta subunit cytosolic domain possesses tyrosine kinase activity. Insulin binding to the alpha subunit extracellular domain activates the beta subunit tyrosine kinase, which autophosphorylates itself and also phosphorylates several intracellular docking or bridging proteins, including so-called insulin receptor, substrate IRS proteins. These molecules in turn activate downstream factors such as PI-3 kinase and AKT, a serine threonine kinase that serves as a central signaling hub that mediates many insulin-dependent activities, including increased glucose uptake, reduced glucose synthesis, and increased glycogen and protein synthesis. Pathogenesis of type 1 diabetes. Tone D is an autoimmune disease in which islet destruction is caused primarily by immune effector cells reacting against endogenous beta cell antigens. T1D most commonly develops in childhood, becomes manifest at puberty, and progresses with age. Because the disease can develop at any age, including late adulthood, the old moniker juvenile onset diabetes is no longer used. Similarly, insulin-dependent diabetes mellitus has been excluded from the current classification of diabetes because many forms of diabetes eventually require treatment with insulin. Nevertheless, most patients with T1D require insulin for survival. Without insulin, they may develop serious metabolic complications such as ketoacidosis and coma. As with most autoimmune diseases, the pathogenesis of T1D involves an interplay of genetic and environmental factors. Genetic susceptibility. Epidemiologic studies, such as those demonstrating higher concordance rates in monozygotic versus dizygotic twins, have convincingly established a genetic basis for T1D. More recently, GWAS have identified multiple genetic susceptibility loci for TD, as well as for TDC later. Of these, the most important locus is the HLA gene cluster, which according to some estimates contributes as much as 50% of the genetic susceptibility for T1D. 90% to 95%. 1102, Chapter 24, the endocrine system. Figure 24, insulin action on a target cell. Insulin binding to the tetrameric receptor initiates a cascade of phosphorylation events that result in activation of PI3 kinase AKT signaling. AKT is a serine threonine kinase that mediates its effector functions via phosphorylation-dependent events. For example, AKT phosphorylates and inhibits the function of the tuberous sclerosis complex TSC proteins, leading to activation of the downstream mammalian TOR-mTOR complex, which enhances protein synthesis. AKT also inhibits the function of forkhead box O-FOXO protein, which in turn reduces glucose synthesis, while inhibition of glycogen synthase kinase 3, GSK3, enhances glycogen production. Finally, AKT enhances intracellular glucose uptake by translocation of GLUT4 vesicles to the cell membrane. IRS, insulin receptor substrate, PI3K, phosphoinositide 3 kinase. Modified from Brendan Manning, Harvard T.H. Chan School of Public Health. Of Caucasians with this disease have either an HLA-DR3 or HLA-DR4 haplotype, in contrast to about 40% of normal subjects. Moreover, 40% to 50% of patients with T1D are DR3, DR4 compound heterozygotes, in contrast to 5% of normal subjects. Individuals who have either DR3 or DR4 concurrently with a DQ8 haplotype demonstrate one of the highest inherited risks for T1D in sibling studies. Predictably, the polymorphisms in the HLA molecules that are associated with risk are located in or adjacent to the peptide binding pockets, consistent with the notion that disease-associated alleles code for HLA molecules that have the capacity to display particular antigens. However, as discussed in Chapter 6, it is still not known how particular HLA alleles contribute to the pathogenesis of T1D and other autoimmune diseases. Several non-HLA genes also confer susceptibility to T1D. The first disease-associated non-MHC gene variant to be identified consisted of variable number of tandem repeats in the promoter region of the insulin gene. The mechanism underlying this association is unknown. It is possible that these polymorphisms influence insulin expression by thymic antigen-presenting cells, thus affecting the negative selection of insulin-reactive T cells. Chapter: The association between polymorphisms in CTLA and PTPN and autoimmune thyroiditis was mentioned earlier. Not surprisingly, these genes have also been linked with susceptibility to TD. The relationship of T1D to altered T cell selection and regulation is also underscored by the striking prevalence of this disease in individuals with rare germline defects in genes that code for immune regulators, such as AIR, mutations of which cause APS1, discussed later. Environmental factors. As in other autoimmune diseases, genetic susceptibility contributes to only a part of diabetes risk, and the concordance rate in monozygotic twins is only about 50%. So, environmental factors must play a role. The nature of these environmental influences remains an enigma. Although antecedent viral infections have been suggested as triggers, neither the type of virus nor how it promotes islet-specific autoimmunity is established. Some studies suggest that viruses might share epitopes with islet antigens, and the immune response to the virus results in cross-reactivity and destruction of islet tissues, a phenomenon known as molecular mimicry. On the other hand, certain infections are also thought to be protective against T1D, mechanisms of beta cell destruction. While the clinical onset of T1D is often abrupt, there is a lengthy lag period between initiation of the autoimmune process and the appearance of symptomatic disease, during which there is progressive loss of insulin reserves. 3 distinct stages of T1D are now recognized, figure 24, 31. In stage 1, autoimmunity positive, normal glycemia, pre-symptomatic T1D, individuals have developed 2 or more islet autoantibodies but are still normoglycemic. In stage autoimmunity positive dysglycemia, pre-symptomatic TD, there is increasingly severe loss of glucose tolerance due to progressive loss of cell mass, but frank symptoms are absent. Nonetheless, the 5-year risk of developing symptomatic T1D increases from less than 50% in stage 1 to 75% in stage 2. Finally, in stage 3, autoimmunity positive, dysglycemia, symptomatic T1D, classic manifestations of the disease, polyuria, polydipsia, polyphagia, ketoacidosis. See later appear, typically after more than 90% of the beta cells have been destroyed. The fundamental immune abnormality in T1D is a failure of self-tolerance in T cells specific for islet antigens. This failure of tolerance may be a result of some combination of defective clonal deletion of self-reactive T cells in the thymus, as well as defects in the functions of regulatory T cells or abnormal resistance of effector T cells to suppress Sion by regulatory cells. Thus, autoreactive T cells not only survive but are poised to respond to self-antigens. The initial activation of these cells is thought to occur in the peripancreatic lymph nodes, perhaps in response to antigens that are released from damaged islets. The activated T cells then traffic to the pancreas, where they cause cell injury. Multiple T cell populations have been implicated in this damage, including Th cells, which may secrete cytokines, including IFN and TNF, that injure cells, and CD/CTLS, which kill cells directly. The islet autoantigens that are the targets of immune attack may include insulin, the beta cell enzyme glutamic acid decarboxylase GAD, and others, consistent with the idea that failure of self-tolerance is fundamental to the pathogenesis of T1D cancer patients. Endocrine pancreas, 1103. Figure 24.31. The 3 stages of type 1 diabetes, modified with permission from Incel Ray Dunn JL, Atkinson Ma et al., staging presymptomatic type 1 diabetes. A scientific statement of JDRF, the Endocrine Society, and the American Diabetes Association. Diabetes Care, 3810, 1964, 1974, 2015. He, treated with immune checkpoint blockade therapy, which disrupts tolerance mechanisms, sometimes develop the disease. A role for antibodies in T1D is suspected because autoantibodies against islet antigens are found in the vast majority of patients with T1D, including at the pre-symptomatic stages of disease, as described earlier. However, it is not clear if the autoantibodies cause injury or are merely a consequence of islet injury. Pathogenesis of type 2 diabetes. T2D is a complex disease that involves the interplay of genetic and environmental factors and a pro-inflammatory state. Unlike T1D, there is no evidence of an autoimmune basis, genetic factors. Genetic susceptibility contributes to the pathogenesis, as evidenced by the disease concordance rate of greater than 90% in monozygotic twins, a rate higher than in T1D. Furthermore, first-degree relatives have twofold higher risk of developing TD than those without a family history, when matched for age and weight. GWAS performed over the past decade have identified at least 30 loci that individually confer a minimal to modest increase in the lifetime risk for T2D. Many of these genes are involved in adipose tissue function through effects on bodily fat distribution, visceral versus subcutaneous islet beta cell function, and obesity. It is believed that together, these genetic polymorphisms conspire to provide the genetic basis for T2D risk. However, heritable risk remains a minor player impacting disease susceptibility, and environmental factors are the major contributors. Environmental factors. The most important environmental risk factor for T2D is obesity, particularly central or visceral obesity. Greater than 80% of individuals with T2D are obese, and the incidence of diabetes worldwide has risen in proportion to obesity. Obesity contributes to the cardinal metabolic abnormalities of diabetes, see later, and to insulin resistance early in disease. In fact, even modest weight loss through dietary modifications can reduce insulin resistance and improve glucose tolerance. A sedentary lifestyle typified by lack of exercise is another risk factor for diabetes, independent of obesity. Weight loss and exercise usually increase insulin sensitivity additively and are often first-line interventions in patients with milder T2D. The combination of obesity, hyperglycemia, increased serum cholesterol and triglycerides, and hypertension is called the metabolic syndrome. Despite this general risk, several populations worldwide in which TD rates are increasing most rapidly, e.g. East Asian, South Asian, and Middle Eastern, do not show comparable increases in obesity, increased body mass index BMI, a measure of total body fat. This has suggested that risk is related not only to the amount of body fat, but also to its anatomic distribution, as discussed later. Sleep disorders such as obstructive sleep apnea and circadian disruption are additional environmental risk factors for T2D. Circadian disruption is defined as misalignment between the endogenous circadian rhythm and the cycle or rhythm created by individual behaviors. Those at risk for circadian disruption include shift workers and those with sleep disorders or other conditions that restrict nighttime sleep and daytime wakefulness. Studies have shown that circadian disruption impairs glucose homeostasis by affecting both insulin secretion and insulin action. In addition, GWAS have shown an association between circadian-controlled genes and TD. Disruption of clock genes not only affects insulin secretion and action, but also activity level and feeding behaviors, resulting in increased risk for hyperglycemia and diabetes. Chapter 24. The Endocrine System. Metabolic defects in type 2 diabetes. The development of T2D involves two key abnormalities: insulin resistance, decreased response of peripheral tissues, especially skeletal muscle, adipose tissue, and liver, to insulin. Beta cell dysfunction, inadequate insulin secretion in the face of insulin resistance, and hyperglycemia. Insulin resistance predates the development of hyperglycemia and is usually accompanied by compensatory beta cell hyperfunction and hyperinsulinemia in the early stages of the evolution of T2D. Figure 24. Over time, the inability of cells to adapt to increasing secretory needs for maintaining a euglycemic state results in chronic hyperglycemia and the resulting long-standing complications of diabetes. Insulin resistance. Insulin resistance is the failure of target tissues to respond normally to insulin. The liver, skeletal muscle, and adipose tissue are the major tissues where insulin resistance gives rise to abnormal glucose tolerance. Insulin resistance results in the following: failure to inhibit endogenous glucose production, gluconeogenesis in the liver, which contributes to high fasting blood glucose levels. Figure 24.3. Development of type 2 diabetes. Insulin resistance associated with obesity is induced by adipokines, free fatty acids FFAs, and chronic inflammation in adipose tissue. Pancreatic beta cells compensate for insulin resistance by hypersecretion of insulin. However, at some point, beta cell compensation is followed by beta cell failure, and diabetes ensues. Reproduced with permission from Kasuga M., insulin resistance and pancreatic beta cell failure. J. Klin Invest 116.7, 1756, 1760, 104. Failure of glucose uptake and glycogen synthesis to occur in skeletal muscle following a meal, which contributes to high postprandial blood glucose level. Failure to inhibit activation of hormone-sensitive lipases in adipose tissue, leading to excess triglyceride breakdown in adipocytes and high levels of circulating free fatty acids, FFAs. A variety of functional defects in the insulin signaling pathway underlie insulin resistance. For example, reduced tyrosine phosphorylation of the insulin receptor and IRS proteins is observed in peripheral tissues, which compromises insulin signaling and reduces the level of the glucose transporter GLUT4 on the cell surface. See Figure 24.30. In fact, one of the mechanisms by which exercise improves insulin sensitivity is by increasing the translocation of GLUT4 to the plasma membrane of skeletal muscle cells. Obesity. Multiple factors contribute to insulin resistance, of which obesity is probably the most important. The risk for diabetes rises as the BMI increases. Not only the absolute amount of fat, but also its distribution determines insulin sensitivity. Central obesity, abdominal fat, is more likely to be linked with insulin resistance than is peripheral gluteal subcutaneous obesity. In fact, individuals from Asia and the Middle East who develop diabetes without overt obesity have primarily visceral adiposity, and it is this increase in visceral fat that appears to engender T2D risk for them. By contrast, individuals who develop primarily subcutaneous adiposity may be relatively protected from T2D. Studies of these so-called metabolically healthy obese individuals is an emerging field. Obesity can adversely impact insulin sensitivity in numerous ways. See Fig, free fatty acids, FFAs. Cross-sectional studies have demonstrated an inverse correlation between fasting plasma, FFAs, and insulin sensitivity. Central adipose tissue is more lipolytic than peripheral sites, which might explain the particularly deleterious consequences of this pattern of fat distribution. Excess FFAs overwhelm the intracellular fatty acid oxidation pathways, leading to the accumulation of cytoplasmic intermediates like diacylglycerol DAG, phospholipids, and sphingolipids, including ceramides. These toxic lipid metabolites can attenuate signaling through the insulin receptor and activate inflammatory pathways in the islets, which further promote beta cell abnormalities. In liver cells, Insulin normally inhibits gluconeogenesis by blocking the activity of phosphoenolpyruvate carboxykinase, the first enzymatic step in this process. Attenuated insulin signaling allows phosphoenolpyruvate carboxykinase to ramp up gluconeogenesis. Excess FFAs also compete with glucose as substrates for oxidation, further exacerbating the reduced glucose utilization. Adipokines. You will recall that adipose tissue is not merely a storage depot for fat, but is also an endocrine organ that releases hormones in response to changes in metabolism. Chapter 9. A variety of proteins secreted into the circulation by adipose tissue have been identified that are collectively termed adipokines or adipose cytokines. Some of these promote hyperglycemia, while others, such 1105, the endocrine pancreas. As leptin and adiponectin decrease blood glucose, in part by increasing insulin sensitivity in peripheral tissues. Adiponectin levels are reduced in obesity, thus contributing to insulin resistance. Inflammation. Over the past several years, inflammation has emerged as an important factor in the pathogenesis of T2D. It is now known that an inflammatory milieu, mediated not by an autoimmune process as in T1D, but rather by pro-inflammatory cytokines that are secreted in response to excess nutrients such as FFAs and glucose, results in both insulin resistance and beta cell dysfunction. Excess FFAs within macrophages and beta cells can activate the inflammasome, a multiprotein cytoplasmic complex that leads to secretion of the cytokine interleukin IL-1 beta, Chapter 3. IL-1 beta, in turn, mediates the secretion of additional pro-inflammatory cytokines from macrophages, islet cells, and other cells. IL-1 and other cytokines act on the major sites of insulin action to promote insulin resistance. Thus, excess FFAs can impede insulin signaling directly within peripheral tissues, as well as indirectly through the release of pro-inflammatory cytokines. Liver steatosis. High circulating levels of FFAs may result in the accumulation of excess fat steatosis in hepatocytes. This form of non-alcoholic fatty liver disease, NAFLD, ranges in severity from hepatic steatosis, without evidence of liver injury, to non-alcoholic steatohepatitis, NASH, with evidence of inflammation and hepatocyte injury with, or without fibrosis. Chapter 18. NAFLD is common in those with metabolic syndrome and T2D, an association that cuts both ways. NAFLD promotes the development of T2D, which in turn increases the risk of developing the more severe forms of NAFLD. Beta cell dysfunction. While insulin resistance by itself can lead to impaired glucose tolerance, beta cell dysfunction is a requirement for the development of overt diabetes. In contrast to the severe genetic defects in cell function that occur in monogenic forms of diabetes, see later, beta cell function actually increases early in the disease process in most patients with sporadic T2D as a compensatory measure to counter insulin resistance and maintain euglycemia. Eventually, however, beta cells seemingly exhaust their capacity to adapt to the long-term demands posed by insulin resistance, and the hyperinsulinemic state gives way to a state of relative insulin deficiency, that is, insulin levels are deficient for the level of blood glucose. Several mechanisms have been implicated in promoting cell dysfunction in TD, including the following: excess FFAs that compromise beta cell function and attenuate insulin release, lipotoxicity. The impact of chronic hyperglycemia, glucotoxicity. An abnormal incretin effect, leading to reduced secretion of G and GLP-1, hormones that promote insulin release, see earlier. Amyloid deposition within islets. This is a characteristic finding in individuals with long-standing T2D, being present in more than 90% of diabetic islets examined, but it is unclear whether it is a cause or an effect of beta cell burnout. Finally, the impact of genetics cannot be discounted, as many of the polymorphisms associated with an increased lifetime risk for T2D occur in genes that control insulin secretion, see earlier. Monogenic forms of diabetes. Although genetically defined causes of diabetes are uncommon, they have been intensively studied in the hope of gaining insights into the disease. As Table 24.6 illustrates, monogenic forms of diabetes are classified separately from types 1 and 2 diabetes. Monogenic forms of diabetes result from either a primary defect in beta cell function or a defect in insulin receptor signaling, described later. Genetic defects in beta cell function. Approximately 1% to 2% of patients with diabetes harbor a primary defect in beta cell function that affects either beta cell mass and/or insulin production. This form of monogenic diabetes is caused by a heterogeneous group of genetic defects. The largest subgroup of patients in this category was designated as having maturity onset diabetes of the young MODY because of its Superficial resemblance to T2D and its occurrence in younger patients. MODY can result from germline loss of function mutations in one of 6 genes, see Table 24.6, of which mutations of glucokinase GCK are the most common. Glucokinase is a rate-limiting step in oxidative glucose metabolism, which in turn is coupled to insulin secretion within islet beta cells, see Figure 24.28. Genetic defects that impair tissue response to insulin. Rare insulin receptor mutations that affect receptor synthesis, insulin binding, or RTK activity can cause severe insulin resistance, accompanied by hyperinsulinemia and diabetes. Type A insulin resistance. Such patients often show a velvety hyperpigmentation of the skin known as acanthosis nigricans. Females with type A insulin resistance also frequently have polycystic ovaries and elevated androgen levels. Diabetes and pregnancy. Pregnancy can be complicated by diabetes in one of 2 settings: when women with pre-existing diabetes become pregnant pregestational, or overt diabetes, or women who were previously euglycemic. Develop impaired glucose tolerance and diabetes for the first time during pregnancy, gestational diabetes. Approximately 5% to 9% of pregnancies occurring in the United States are complicated by hyperglycemia, and the incidence of both pregestational and gestational diabetes is increasing in the general population. Pregnancy is a diabetogenic state in which the prevailing hormonal milieu favors insulin resistance. In a previously euglycemic woman who is otherwise susceptible due to concurrent genetic and environmental factors, the consequence may be gestational diabetes. Of even greater concern, women with pregestational diabetes have an increased risk of stillbirth and congenital malformations in the fetus. Poorly controlled diabetes that arises later in pregnancy, regardless of prior history, can lead to excessive birth weight in the newborn, macrosomia, and may have long-term sequelae for the child later in life, including an increased risk of obesity and diabetes. Gestational diabetes typically resolves following delivery. However, the majority of affected women develop overt diabetes over the next 10 to 20 years. 1106, Chapter 24, The Endocrine System. Clinical features of diabetes. It is difficult to sketch with brevity the diverse clinical presentations of diabetes. We will discuss the most common initial presentation or mode of diagnosis for each of the 2 major subtypes, followed by a discussion of acute and then chronic long-term complications of the disease. TD may arise at any age. In the initial or years following the onset of overt TD, exogenous insulin requirements may be minimal because of residual endogenous insulin secretion referred to as the honeymoon period. Eventually, however, beta cell function declines to a tipping point, and insulin requirements increase dramatically. Although beta cell destruction is a prolonged process, the transition from impaired glucose tolerance stage 2 see earlier to overt diabetes stage 3 may be abrupt and is often brought on by a superimposed stress, such as infection, because of associated increase in insulin requirements. In contrast to TD, TD is typically seen in obese patients older than years of age. However, it is now being diagnosed in children and adolescents with increasing frequency due to increases in obesity and sedentary lifestyle. In some cases, medical attention is sought because of unexplained fatigue, dizziness, or blurred vision. Most frequently, however, the diagnosis of T2D is made after routine blood testing in asymptomatic persons. In fact, in light of the large number of asymptomatic individuals with undiagnosed hyperglycemia in the United States, routine blood glucose testing is recommended for everyone older than 45 years of age, and in younger individuals with obesity, family history, or the presence of the metabolic syndrome. The classic triad of diabetes. The onset of TD is usually marked by the triad of polyuria, polydipsia, polyphagia, and when severe, diabetic ketoacidosis, all resulting from metabolic derangements. Because insulin is a major anabolic hormone, its deficiency results in a catabolic state that affects glucose, fat, and protein metabolism. Unopposed secretion of counterregulatory hormones such as glucagon also plays a role in these metabolic derangements. The assimilation of glucose into muscle and adipose tissue is sharply diminished or abolished. Not only does storage of glycogen in liver and muscle cease, but reserves are depleted by glycogenolysis. The resultant hyperglycemia leads to filtration of so much glucose in the kidney that the renal tubular threshold for reabsorption is exceeded. This leads to glycosuria, which induces an osmotic diuresis and thus polyuria, causing a profound loss of water and electrolytes, Fig. The renal water loss combined with the hyperosmolarity owing to increased levels of glucose in the blood depletes intracellular water, triggering the osmoreceptors of the thirst centers of the brain. Thus, intense thirst polydipsia appears. With a deficiency of insulin, the scales swing from insulin-promoted anabolism to catabolism of proteins and fats. Proteolysis follows, releasing gluconeogenic amino acids that are removed by the liver and used as building blocks for glucose. The catabolism of proteins and fats tends to induce a negative energy balance, which in turn leads to increasing appetite polyphagia, thus completing the classic triad of polyuria, polydipsia, and polyphagia. Despite the increased appetite, catabolic effects prevail, resulting in weight loss and muscle weakness. The combination of polyphagia and weight loss is paradoxical and should always raise the suspicion of diabetes. Acute metabolic complications of diabetes. Diabetic ketoacidosis is a severe acute metabolic complication of T1D. It is not as common or as severe in T2D. The most frequent precipitating factor is a failure to take insulin, although other stressors such as infections, other illnesses, trauma, and certain drugs may also serve as triggers. It may also occur less commonly in T2D, but only under condition of very severe stress, such as caused by serious infections and trauma. Many of these factors are associated with the release of the catecholamine epinephrine, which blocks residual insulin action and stimulates the secretion of glucagon. The insulin deficiency coupled with glucagon excess decreases peripheral utilization of glucose, while increasing gluconeogenesis, severely exacerbating hyperglycemia. The plasma glucose levels are usually in the range of 250 to 600 milligrams DL. The hyperglycemia causes an osmotic diuresis and dehydration characteristic of the ketoacidotic state. A second major effect of insulin deficiency is increased synthesis of ketone bodies. Insulin deficiency stimulates hormone-sensitive lipase, with a resultant breakdown of adipose stores and an increase in levels of FFAs. When these FFAs reach the liver, they are esterified to fatty acyl coenzyme A. Oxidation of fatty acyl coenzyme A molecules within the hepatic mitochondria produces ketone bodies, acetoacetic acid and beta-hydroxybutyric acid. The rate at which ketone bodies are formed may exceed the rate at which they can be utilized by peripheral tissues, leading to ketonemia and ketonuria. If the urinary excretion of ketones is compromised by dehydration, the result is a systemic metabolic ketoacidosis. Release of ketogenic amino acids by protein catabolism aggravates the ketotic state. The clinical manifestations of diabetic ketoacidosis include fatigue, nausea, and vomiting, severe abdominal pain, a characteristic fruity odor, and deep labored breathing, also known as Kussmaul breathing. Persistence of the ketotic state eventually leads to depressed consciousness and coma. Reversal of ketoacidosis requires administration of insulin, correction of metabolic acidosis, and treatment of any underlying precipitating factors, such as infection. The lower frequency of ketoacidosis in T2D is believed to be due to higher portal vein insulin levels in these patients, which prevents unrestricted hepatic fatty acid oxidation and keeps the formation of ketone bodies in check. Instead, patients with T2D may develop a condition known as hyperosmolar hyperglycemic state due to severe dehydration resulting from sustained osmotic diuresis, particularly in patients who do not drink enough water to compensate for urinary losses from chronic hyperglycemia. Typically, this occurs in an older patient who has diabetes and is disabled by a stroke or an infection and thus unable to maintain adequate water intake. Furthermore, the absence of ketoacidosis and its symptoms, nausea, vomiting, Kussmaul breathing, delays the seeking of medical attention until severe dehydration and impairment of mental status occur. The hyperglycemia is usually more severe than in diabetic ketoacidosis, in the range of 600 to 1,200 milligrams DL. Once treatment commences, ironically, the most common acute metabolic complication in either type of diabetes is the endocrine pancreas, 1107. Figure 24.33. Sequence of metabolic derangements underlying the clinical manifestations of diabetes. An absolute insulin deficiency leads to a catabolic state, culminating in ketoacidosis and severe volume depletion. These cause sufficient central nervous system compromise to lead to coma and eventual death if left untreated. Hypoglycemia. Causes include missing a meal, excessive physical exertion, excessive insulin administration, or misdosing during the phase of dose finding for anti-diabetic agents such as sulfonylureas. The signs and symptoms of hypoglycemia include dizziness, confusion, sweating, palpitations, and tachycardia. If hypoglycemia persists, loss of consciousness may occur. Rapid reversal of hypoglycemia through oral or intravenous glucose intake is critical for preventing permanent neurologic damage. Chronic complications of diabetes. The morbidity associated with long-standing diabetes of either type is due to damage induced in large and medium-sized muscular arteries, diabetic macrovascular disease, and in small vessels, diabetic microvascular disease, by chronic hyperglycemia. Macrovascular disease causes accelerated atherosclerosis among patients with diabetes, resulting in increased risk of myocardial infarction, stroke, and lower extremity ischemia. The effects of microvascular disease are most profound in the retina, kidneys, and peripheral nerves, resulting in diabetic retinopathy, nephropathy, and neuropathy, respectively. See later. Pathogenesis. Persistent hyperglycemia glucotoxicity seems to be responsible for the long-term complications of diabetes. Much of the evidence supporting a role for glycemic control in ameliorating the long-term complications of diabetes has come from large randomized trials. The assessment of glycemic control in these trials has been based on the percentage of glycated hemoglobin, also known as HbA1c, which is formed by non-enzymatic covalent addition of glucose moieties to hemoglobin in red cells. Unlike blood glucose levels, HbA1c provides a measure of glycemic control over the lifespan of a red cell 120 days and is affected little by day-to-day variation in glucose levels. It is recommended that HbA1c be maintained below 7% in patients with diabetes. The emergence of new technology, including 1108. Chapter 24, the Endocrine System. Continuous glucose monitoring systems has introduced a new goal, increasing time in range set at 70 to 180 milligrams DL, which may be a better predictor of the risk of chronic complications than HbA1c level. It is important to stress, however, that hyperglycemia is not the only factor responsible for the long-term complications of diabetes, and that other underlying abnormalities such as insulin resistance and comorbidities like obesity also play an important role. At least 4 distinct mechanisms have been implicated in the deleterious effects of persistent hyperglycemia on peripheral tissues. In each proposed mechanism, increased flux through metabolic pathways due to hyperglycemia is thought to generate harmful precursors that contribute to end organ damage. Formation of advanced glycation end products. Advanced glycation end products, AGEs, are formed as a result of non-enzymatic reactions between glucose-derived metabolites, glyoxal, methylglyoxal, and 3-deoxyglucosone, and the amino groups of intracellular and extracellular proteins. The rate of AGE formation is accelerated by hyperglycemia. AGEs bind to a specific receptor, RAGE, that is expressed on inflammatory cells, macrophages, and T cells, endothelium, and vascular smooth muscle. The detrimental effects of the AGE-RAGE signaling axis within the vascular compartment include the following: release of cytokines and growth factors, including transforming growth factor TGF-beta, which leads to deposition of excess basement membrane material, and vascular endothelial growth factor VEGF, implicated in diabetic retinopathy. See later. Generation of reactive oxygen species ROS in endothelial cells, increased procoagulant activity on endothelial cells and macrophages, enhanced proliferation of vascular smooth muscle cells, and synthesis of extracellular matrix. Not surprisingly, endothelium-specific overexpression of RAGE in diabetic mice accelerates large vessel injury and microangiopathy, while RAGE-null mice show attenuation of these features. Antagonists of RAGE have emerged as therapeutic agents in diabetes and are being tested in clinical trials. In addition to receptor-mediated effects, AGEs can directly cross-link extracellular matrix proteins. Cross-linking of collagen type 1 molecules in large vessels decreases their elasticity, which may predispose these vessels to shear stress and endothelial injury. Chapter. Similarly, age-induced cross-linking of type 4 collagen in basement membrane decreases endothelial cell adhesion and increases extravasation of fluid. Proteins cross-linked by AGEs are resistant to proteolytic digestion. Thus, cross-linking decreases protein removal, enhancing protein accumulation. Age-modified matrix components also trap non-glycated plasma or interstitial proteins. In large vessels, trapping of LDL, for example, retards its efflux from the vessel wall and contributes to the deposition of cholesterol in the intima, thus accelerating atherogenesis. Chapter. In capillaries, including those of renal glomeruli, plasma proteins such as albumin bind to the glycated basement membrane, accounting in part for the basement membrane thickening that is characteristic of diabetic microangiopathy. Activation of protein kinase C, calcium-dependent activation of intracellular protein kinase C, PKC, and the second messenger diacylglycerol, DAG, is an important signal transduction pathway. Intracellular hyperglycemia stimulates the de novo synthesis of DAG from glycolytic intermediates, and hence causes excessive PKC activation. The downstream effects of PKC activation are numerous, including production of VEGF, TGF-beta, and the procoagulant protein plasminogen activator inhibitor 1-PI1 chapter 4 by the vascular endothelium. It should be evident that some effects of AGEs and activated PKC are overlapping, and both likely contribute to diabetic microangiopathy, oxidative stress, and disturbances in polyol pathways. Even in tissues that do not require insulin for glucose transport, e.g., nerves, lenses, kidneys, blood vessels, persistent hyperglycemia leads to an increase in intracellular glucose. This excess glucose is metabolized by the enzyme aldose reductase to sorbitol, a polyol, and eventually to fructose, in a reaction that uses NADPH, the reduced form of nicotinamide dinucleotide phosphate, as a cofactor. NADPH is also required by the enzyme glutathione reductase, in a reaction that regenerates reduced glutathione, GSH. GSH is one of the important antioxidant mechanisms in the cell chapter 2, and any reduction in GSH increases cellular susceptibility to reactive oxygen species oxidative stress. In the face of sustained hyperglycemia, progressive depletion of intracellular NADPH by aldose reductase compromises GSH regeneration, increasing cellular susceptibility to oxidative stress. Sorbitol accumulation in the lens contributes to cataract formation, hexosamine pathways, and generation of fructose 6-phosphate. Finally, it is postulated that hyperglycemia induces flux of glycolytic intermediates through the hexosamine pathway, which results in cell damage and enhanced oxidative stress. Morphology of chronic complications of diabetes. The important morphologic changes are related to the many late systemic complications of diabetes. As discussed earlier, these changes are seen in both T1D and T2D. Figure 24. Morphology. Pancreas. Alterations in the pancreas are inconstant and often subtle. Distinctive changes are more commonly associated with T1D than with T2D. One or more of the following alterations may be present. Reduction in the number and size of islets. This is most often seen in T1D, particularly with rapidly advancing disease. Most of the islets are small and inconspicuous. Leukocytic infiltrates in the islets insulatus are principally composed of T lymphocytes and are also seen in animal models of autoimmune diabetes. Figure 24. Lymphocytic infiltrates may be present in T1D at the time of clinical presentation. In T2D, there may be a subtle reduction in islet cell mass, demonstrated only by special morphometric studies. Amyloid deposition within islets in T2D begins in and around capillaries and between cells. At advanced stages, the 1109. The endocrine pancreas. Figure 24. Long